Ladies and gentlemen, thank you for standing by, and welcome to the Myocarditis Foundation Chronic Myopericarditis conference call. If you need to reach an operator at any time during this conference, please press *0. As a reminder, this conference is being recorded Thursday, September 15th, 2011. It is now my pleasure to turn the conference to Dr. Cooper. Please go ahead, sir.
Thank you, David, and good afternoon. Welcome to the Myocarditis Foundation webinar on chronic myopericarditis. I'm Leslie Cooper, physician and cardiologist at the Mayo Clinic in Rochester, Minnesota. Today's topic is on the unusual entity of chronic inflammation of the heart and the lining of the heart, the myocardium and the pericardium, which together we contract to the single word myopericardium, or in this case myopericarditis, to mean inflammation of those adjacent structures. And we're just going to cover two topics, really. The first is what the definition is and etiology, and the second is what the management typically is. I would emphasize at this point that there are no standard guidelines for management of this entity because it is rare. And so most management is based on expert opinion. Now, in contrast to acute myocarditis, which generally presents with heart failure, but sometimes with a loss of consciousness due to arrhythmias, either fast arrhythmias or slow ones due to heart block, or with chest pain. In contrast to the acute presentation, chronic or chronic recurrent myocarditis presents almost always with chest pain. And interestingly, it's usually in men. It's also can present with recurrent heart failure, particularly after weaning off of standard heart failure medications. But that is an uncommon circumstance that affects perhaps only 10% of people who have recovered from acute myocarditis. The injuries that lead to acute myocarditis I'll review, and these are most commonly viruses in the Western world, and there are about 20 viruses. The famous ones are Coxsackie A and B, named after the town of Coxsackie, New York, in the Hudson River Valley, as well as adenovirus, which is a common cold virus, and parvovirus B19, which causes Fifth's disease in children. In addition, there are numerous kinds of chemotherapy, radiation therapy, and other allergic drug reactions that can cause myocarditis that are all fairly infrequent. I should emphasize that the causes of myocarditis in other parts of the world, most of Africa, for example, and Asia, is simply not known because there are few facilities that can make the diagnosis. In chronic myocarditis, there are really two possibilities. One is that these injuries can recur if you have a new virus, for example, one that you were not exposed to before that could affect the heart. You could have another episode of myocarditis or myopericarditis. It turns out the same viruses cause pericarditis that cause myocarditis. And that is not uncommon. The other possibility, the second bullet point here, is that you had a new recognition of an old trigger. And what I mean by that is the initial episode of myocarditis, in the initial episode of myocarditis, your immune system could have mistaken your heart or the lining of the heart, the pericardium, for a foreign body like a virus or a bacteria and caused an autoimmune reaction. In most cases, these autoimmune reactions simply go away after a couple of weeks. The immune system automatically downregulates. In some people, for reasons that are not clear, this can happen again. And the same endogenous trigger, meaning the surface of the heart or the pericardium, can cause an autoimmune reaction again. The triggers are not well defined, but it doesn't mean you have a new infection. It means, in this case, that you have an autoimmune reaction against the heart. And then there's the possibility that there's simply a different syndrome, that the new chest pain or the new heart failure syndrome is due to a completely different cause, like coronary artery disease, for example. This slide is a bit complicated, but I want to walk you through it. And this goes over the sequentially, starting at the top left, the injury, the pathway from injury with a virus or toxin down to the outcomes, meaning at the bottom on the left, a normal heart, or on the bottom right, a heart muscle disease called a cardiomyopathy. So in this illustration, after you get an initial injury in the heart, generally a virus, but sometimes a toxin or other injury, myocytes die. Myocytes are heart muscle cells. When they're injured, they can die. And when they die, they release their contents. And their contents become visible to the immune system. The immune system doesn't see inside of cells, but it does see everything outside of the cells. And this is a danger signal to the immune system. You get a reaction that initially begins with constitutive or innate forms of immunity in the form of certain kinds of T lymphocytes and cytokines, which are the protein products of these cells. That then stimulates a very specific response against these proteins and contents of the dead myocytes. That reaction, that immune reaction, can amplify very quickly over the course of days to cause substantial additional injury in the region of the initial infection or toxin attack. Over the next, then in the next circle, halfway down on the right, you can see that the initial T cell in blue and B cell in purple react, cause the inflammation, and then in most people, the left arrow is followed. The viruses are cleared, the immune system downregulates, and everything goes back to normal. But in a few people, maybe a third with acute heart failure, they end up with a dilated cardiomyopathy illustrated by the large heart. And in both of these circumstances, this same pathway can happen again. The next slide, and that would be in the setting of chronic or chronic recurrent myocarditis. This next slide is mostly for the molecular biologists who might be listening to this, and it shows why men are perhaps more likely to be affected by this syndrome than women. I mentioned in the beginning that it's mostly men who have this chronic recurrent pattern of inflammation, and on the left, those blue circles are supposed to be testosterone, here TE, and which is, of course, 10 times higher in men than women. And that testosterone drives processes both in inflammatory cells in the blue and in non-inflammatory cardiac cells like muscle cells, myocytes, or fibroblasts to generate a specific kind of hormone-driven immune reaction characterized on the middle part on the right by an increase in IL-1 beta, which releases soluble, that's small s, ST2, into blood vessels, which can be detected in the vein blood that we draw for normal blood tests. And this process, which is testosterone-driven, causes a worse syndrome of heart failure, worse dilated cardiomyopathy, and probably allows for more recurrence of the initial injury. If you are someone who looks under microscopes for a living, you'd recognize this as a microscopic illustration of myocarditis. The purple, or I should say pink, cells in the background toward the top are heart muscle cells that are normal. As you move toward the middle and bottom, they are damaged and they look purple, kind of a blotchy purple. And the cells, the little blue dots, are lymphocytes, which are invading that area of damaged cells. This is what myocarditis looks like under a microscope, and this is what happens primarily in acute disease, but can also, to a lesser degree, characterize chronic myocarditis or chronic recurrent myocarditis, which is our topic today. The electrocardiogram, which I hope you're familiar with, is simply a non-invasive test of the electrical activity of the heart. It has a very low sensitivity, meaning it really doesn't pick up most of these cases. Sometimes it does, but not usually. I say that just to point out the lack of utility or sensitivity of this test. Instead, we use more sophisticated tests like cardiac MRI or heart biopsy when indicated. And this is a picture of a cardiac MRI. The heart in cross-section here is full of blood, and the blood is kind of a light gray, and the heart muscle is kind of a black color. And you can see the white arrows are pointing to white regions inside of the heart muscle, and those white regions are areas of damage from myocarditis. So we can image myocarditis with this technique without doing any biopsy, which of course is safe. And the problem is that once you get these white spots with the acute injury, they don't go away. And they stay there. Even if the acute injury goes away and the myocarditis resolves and you feel great, the problem is the white spots are still there. So we really can't tell if you have another episode of myocarditis because the original injury is getting in the way and confounding the diagnosis. It only points here to the gaps in our ability to make the diagnosis accurately in the chronic setting. So how do we manage this? There are guidelines for the management of heart failure, which are listed here. These are three guidelines that are used in the United States and Europe. They're very similar. And I won't go into any of the details, but suffice it to say that they're broadly used and applied across Europe and North America. In terms of chronic chest pain, which is not heart failure, that requires often medicines like colchicine or ibuprofen given in particularly high doses for a short period of time, followed by a taper over a few weeks to months in the acute and in the chronic setting. And in addition, for chronic myocarditis, there are a couple of specific treatments. This slide illustrates a research paper that was published about 2 years ago in the European Heart Journal. It's a frequently cited paper by a group in Rome led by Andrea Frustacci. And this was a study of immunosuppressive therapy for patients who had chronic myocarditis. And in this study, about 85 people were studied in a randomized fashion. Half got immunosuppressive therapy and half got placebo control therapy. And the ones that got the immunosuppressive therapy did quite well with an improvement in their heart function, as you can see, from 26 to 46% ejection fraction at 6 months, which is a very impressive increase. That kind of increase we don't usually see in drug trials, and I'm not sure that it will be reproduced in larger multi-center studies, but at least the data that exists today suggests that in people with chronic myocarditis and heart dysfunction, that they could benefit from a short course of immunosuppressive therapy. And then there's another group in Berlin that produced a paper that is not yet published but has been reported here called the BICC trial, BICC, and these are people who have viruses in the heart, who have chronic myocarditis, and these viruses were mainly parvovirus B19. There were a few other viruses, about 15 of the 143 people had other viruses, and essentially what they showed in the next slide is that when you gave a medicine called Interferon by subcutaneous injection in the belly 3 times a week, that you could improve symptoms and decrease the virus load in the heart. And so that's another potential therapy which is on the horizon. We don't do this typically in the United States yet, but on occasion I do perform heart biopsy for this indication and have seen some dramatic improvements occasionally. So with that, I'd like to remind everyone that this is the Myocarditis Foundation that is sponsoring this webinar, and that's our website, my email if you have any questions, and the grant deadline for grant submissions if you are a researcher. And with that, we will wrap up the didactic portion and take any questions. Thank you.